Thank you, Mr. Chairman, and thank you to BioMerieux for inviting me. Great. So I was asked to address the issue and the complexity of AKI awareness, which is obviously a major issue in clinical practice. Although we all consider ourselves experts in AKI, there are many people we're working with who have less understanding and less knowledge about AKI. AKI is common, you all know this. It occurs worldwide and affects people worldwide, in particular those in hospital. It's estimated that more than 100 million people per year develop acute kidney injury. So it's a major problem, a pandemic. It's associated with serious short and long-term complications. And as you all know, as we've heard throughout the conference, patients with AKI have a higher risk of dying. The risk of dying is higher in those with more severe acute kidney injury. And in fact, it is thought that the risk of dying from AKI is actually higher compared to that of other common comorbidities, including common cancers. And not surprisingly, it's associated with a longer stay in hospital and healthcare costs. And this is what alerted the administrators in the National Health Service in the UK to be more aware of acute kidney injury. And they were sent this journal about 10 years ago, informing them that AKI was a serious problem in the NHS. And in fact, they called AKI a killing illness. Now, this mainly referred to mortality, but obviously we have to remember that the burden is much wider. So survivors of acute kidney injury remain at high risk of other long-term complications, including CKD, becoming prematurely dialysis dependent, and having a much higher risk of cardiovascular complications. All of this, again, prompted the government in the UK to address the issue by setting up a campaign which was called Think Kidneys. And the idea was to inform healthcare professionals, but also the public a little bit more about the importance of the kidneys and the complexity and concern about acute kidney injury. And as part of this, Ipsos arranged a survey amongst the lay population just to test their knowledge. And they were sent various questions, including this one here. Which, if any of the following things, do you think your kidneys can do? And it was shocking to see that about 50% of people did not know that the kidneys make urine. So this was the standard, the level of knowledge amongst the lay population. And then various publicity campaigns started to at least raise a bit more awareness amongst the lay population. But the question is, how much do our colleagues in other specialties know? What is the awareness among cardiologists, ED clinicians, or oncologists? And again, this was the focus of another survey conducted by Ipsos and supported by BioMerieux, where they asked 1,000 clinicians from different countries and different backgrounds about various aspects related to acute kidney injury. Now, of note, these were all clinicians who had been active practicing for at least 2 years in either ED or any of these acute specialties. And they were all involved in making decisions about management and prescribing. As shown here, 3 out of 4 clinicians who are at least between 50 to 100 patients at risk of AKI or with AKI per week. So a group of healthcare professionals who routinely see patients who are either at risk of AKI or have AKI. Now, I can't, for time reasons, I can't show you the whole survey, but I'll give you some highlights. 40% said they used guidelines. That means 60% said they didn't really use any guidelines. They used their own clinical judgment to look after patients with AKI. And when they were asked various other questions, of concern was the fact that 70% admitted missing AKI on a regular basis. And then they asked also about their general knowledge about acute kidney injury and whether they knew that acute kidney injury was associated with long-term complications. And this was only known to 2 out of 3. So 1 out of 3 did not know that AKI had longer-term complications. So this is the state of our knowledge of our colleagues across the world. And I put it to you that it's up to us to inform them and to act as advocates and to raise more awareness. And before I talk about advocacy, I just want to give you 3 questions to think about. So would you be concerned if colleagues in your hospital did not follow a protocol for the management post-MI? Would you be alarmed if acute strokes were missed in the ED department? And would you be worried if patients with an MI were discharged without any follow-up, sometimes not even be told they had an MI? If the answer is yes to any of these questions, then clearly you are one of the people who are concerned about AKI as well. And that means we all have a duty here to act as advocates for patients at risk of AKI or with AKI. And that means different things. It may mean that we have to do a bit more education. It may mean that we have to get involved in clinical governance and identify those cases that have been missed. It may mean that we just have to fight harder for patients who are at risk of AKI and get more resources in. But it may also mean that we have more duties outside the hospital and raise more awareness amongst patients who have had AKI. And I put it to colleagues here from industry. I believe they also have a duty in helping us, raising more awareness. Thank you very much for your attention.
So we follow up immediately with your presentation, and if we have time, we will leave some time for question. And you're talking about new tools for decision making. Are biomarkers new tools?
Thank you, Claudio. Excellent talk, Marlies. It's, I think, dovetails nicely with what I'm going to talk about. I'm going to just, sort of start out with a case to try to get some context for what we're going to be speaking about. So consider this 68-year-old female, we'll say, with a history of asthma, non-insulin dependent diabetes, who presents with a fever and a cough, right? I mean, you see this kind of case day in and day out. Chest X-ray suspicious of a left lower lobe infiltrate. In the emergency department, the blood pressure falls a bit, and they're started on norepinephrine in addition to fluids. They're transferred to the ICU. Patient arrives in your unit, and I'm an intensivist, so I see these patients day in and day out. Comes up from the emergency department on vancomycin and piptazo, my 2 least favorite antibiotics, and certainly the kidney's 2 least favorite antibiotics, maybe second only to gentamicin and other aminoglycosides. The creatinine, though, is 1.2. Which is baseline for this patient, hasn't changed, and the urine output is okay. So what do? Do you change the antibiotics? It's a kind of a soft indication, but people will say, a lot of emergency room doctors say, well, I got patients in septic shock. I've got to cover, resistant organisms, even though there may not be a strong indication. How many of the people in this room would change the antibiotics? Be honest. Would you change the antibiotics? Would you change the antibiotics? So the rest of you would not. I said, who wouldn't change the antibiotics? All the other hands should go up, right? Oh, come on. Who would not change antibiotics? Okay, I'm still not seeing all the hands, but okay, fine. So now it's the next morning.
What do the rest?
Yeah, I know. You can't either change or not change. It's dichotomous, right? So here's the next morning. The creatinine is 1.2. And the urine output is good, and the fluid balance is only positive 1.5 liters. So all of you said that you were going to not change the antibiotics. You can turn to the ones who said they were going to change it. It looks superior, okay? But what if it was this? Okay, this is the real answer. This is what happened. So all of you said you were going to change the antibiotics. You can look at the other people who said they weren't going to change the antibiotics and look superior, okay? But, we just don't know, right? I mean, not everybody raised their hand, but of the ones that raised their hand, about is 50-50, right? It's great uncertainty as to what we should do. Wouldn't you like to know the answer? So this is what it looks like for Nefrocheck and for TIM2, IGF-BP7, and vancomycin, right? People who develop stage 2 or 3 AKI, doubling of serum creatinine or profound oliguria, have a much higher level of TIM2 and IGF-BP7 in their urine. So this is one of the reasons I routinely use the test, because if the patient comes up to my unit and I have that uncertainty, I have something to use to make the judgment, right? So why should this work? Well, these biomarkers are markers. This is really the fundamental issue. These are markers of kidney stress. If the kidney is under stress, it may be from a number of different reasons, but here we're contemplating that it's from one of these two nephrotoxic or both of these nephrotoxic drugs. And so what is kidney stress? Right? It's a response to non-lethal cell injury or noxious stimuli. It may induce a protective response pattern or downregulation of non-vital cell functions. It's different than damage, although sustained stress is synonymous with damage. And urine TIMP2 and IGF-BP7 have been clearly shown to demonstrate high predictive accuracy for the development of subsequent stage 2, 3 AKI. Okay, this is not just a minor blip. This is a card-carrying kidney injury event. This occurs rapidly, as been shown in this study in cardiac surgical patients, so literally while the patient was still under anesthesia undergoing cardiac surgery. And in this study in the animal lab, Dick Zager's group showed that these are preformed proteins. They come out very, very rapidly. So the patient comes up from the emergency room. They just received a dose of vancomycin. Some people say, oh, it's too early to tell. But no, this happens within minutes, okay? It probably happens within microseconds, and it takes minutes for the urine to come out of the kidney so you can measure it in the bladder. And that's not the only thing you can do, of course, right? The KDIGO guideline has lots of different actions which you're on the fence about. I know you're on the fence about it because I know that only 5% of patients receive all of the KDIGO actions. 5%, that's what the Akiki 2 trial showed, and these were hospitals across Europe. Many of your hospitals were represented. So this is an opportunity to use this decision-making tool in your daily practice. And Alex Arbach has shown that when you use it to decide to implement a KDIGO bundle, and let's face it, you don't implement KDIGO bundles as often as you should, and maybe you should, maybe you don't need to. We never said in the KDIGO, we never said you had to do all these things. We said you had to consider. But as we've demonstrated, you've considered it, and half of you decided you didn't need to change the antibiotics, and half of you decided you did need to change the antibiotics. So clearly you need more help making that decision. And Alex Arbach has shown that when you implement the KDIGO bundle, you dramatically reduce the rate of stage 2, 3 AKI. But again, only a fraction of the patients were biomarker positive. So you'd have wasted your time and your precious hospital's money if you would have implemented the KDIGO bundle on all patients. So the next time someone tells you, oh, I don't need a biomarker because I do everything, you send them straight to the hospital administrator, because you shouldn't be doing everything. You should be doing the right things for the right patients, right? And biomarkers will allow you to do that. Now, this stress issue, I think, is very important, because if you find that you have stress in the kidney, the most important thing you can do is figure out why the kidney's under stress, right? The kidney's in peril. It's under stress. It's sending out a warning signal, right? Why is that? Is it because of the drugs that we just talked about? We can stop those drugs. We can dose them differently. Is there an infection we hadn't actually thought about? Do we have source control? Yeah, the patient's got a left lower lobe pneumonia, but maybe they don't really have a left lower pneumonia. Maybe they actually have something in the abdomen that's causing the chest x-ray to look abnormal. Maybe we need to do a CT scan. Do they have heart failure? Do they have intra-abdominal hypertension? Do they have an unusual cause? Do they actually need a card-carrying nephrologist to come and look at the patient and do whatever the card-carrying nephrologist does, look at the urine and things like that, right? Hocus pocus. But, patients have glomerulonephritis sometimes. They have interstitial nephritis. They have, crystal disease. It happens, and you miss it all the time, trust me. Get the fluids right? Not just too high, but also too low, and avoid other insults. So, it's not the only thing, but stress is what this marker is detecting, right? This is stress, okay? It's actually a protective response. Getting the zebras to run faster away from the lion is actually a good thing, but it tells you that the zebra's under stress. If you didn't know the lion was there, be an important clue that something is dangerous for this zebra. That's different from damage. A sustained rise in TIMP2 and IGF-PP7 is synonymous with damage, but a transient blip is synonymous with stress. And then there's the issue of, well, will the damage go away? Is it reversible? If the CCL14 value, which is a new biomarker that will be available to all of you very soon, in fact, the very first clinical non-research application of CCL14 occurred about 3 hours ago in Spain. I get an alert. And a low CCL14 value tells you that the damage is most likely reversible. Maybe because you did something good already, you stopped the vancomycin and the piptazo, good for you. Maybe it's because the event was transient. They had cardiac surgery and there's no more insult and it's going to go away and you don't have to do anything more. These are the patterns of death, dialysis, and persistent renal dysfunction amongst patients with different levels of CCL14. So just like an elevated TIMP2 and IGF-PP7 tells you that there's stress, an elevated CCL14 tells you that there is injury that's non-reversible, at least not immediately reversible, in the kidney. And you should act appropriately. What would you do? So, okay, let's go back to our patient. Okay, let's say they did have this second scenario. Now you'd measure a CCL14, and the CCL14 value is low. Okay, great. I stopped the antibiotics, or maybe now I've stopped the antibiotics because I didn't listen to the other half of the people who said to stop them before and change them to something less nephrotoxic. The CCL14 value is low. So I don't need to do anything else. It probably should just be standard of care at that point. But if the CCL14 value is above 1.3, then I really need to go back and look again to see if there's anything else I can do because this kidney's not going to get better. And I may well need to go talk to the patient or talk to the family and say, I screwed up. I should have listened to the people who said to stop. No, you should say, well, maybe you should say that, but you should say, I may have to start dialysis because your kidney's not going to get better. And I'm not saying you start dialysis because of this test, but you certainly should start thinking about it because the test tells you with high predictive accuracy that the patient's going to have persistent acute kidney injury. So in conclusion, renal stress response occurs even non-lethal cell injury or noxious stimuli and may include a protective response pattern or downregulation of non-vital cell function. It's like the zebra getting very excited and running from the lion. Markers of cell cycle arrest appear to be measures of kidney stress rather than damage per se, although persistent stress is synonymous with damage. The most important approach in managing kidney stress is to find the cause and eliminate it. CCL14, by contrast, is a marker of persistent AKI. Patients with CCL14 greater than 1.3 are less likely to recover kidney function in the short term over the next few days. The clinical utility, and I just want to leave you with this point because it's an important one for your colleagues. The clinical utility of these biomarkers really is only demonstrable with clinical experience. I ran these trials. Okay, I was the PI of these trials to qualify NephroCheck. I was the co-PI for the trial for CCL14. I didn't know how to use NephroCheck at the bedside until I actually used the test at the bedside. Okay, and I use it differently now than I did when I started. So these tests, like any test, you need to get a feel for it clinically. And you'll find the strongest opposition to biomarkers exist amongst people who've never used them. With that, I thank you for your attention.
Thank you. Marlies, do you want to join for a 5-minute discussion? At the end of this presentation, just a question. How many of you are using more or less routinely, or in some cases, these biomarkers, the new AKI biomarkers. Okay. How many of you are convinced they should be using these biomarkers, but they have problems of different nature? Okay, how many of you think it's too early to use these biomarkers in clinical routine? Nobody.
How many are worried that they may get treated like Peter Peters?
No, I think, John, since last year, the percent of responses have changed significantly, because it's very hard to convince the people outside this audience if this audience is not convinced. But today, it seems that the audience is convinced. Some people are using the biomarkers, so we have to solve the challenges for the application. But I very much agreeing with John. Once you use the biomarker, you learn how to use it. And my impression is that the more we will use, the more the price will go down, because it will become a test. But, and I have to commend BioMerieux because they have created this AKI awareness campaign, we need to tell people that AKI is dangerous. But it seems sometimes this is difficult. So, how was your way for use in your center? Maybe a quick response from both of you.
So I can start. So I was involved in the trial, so I've had been involved in the biomarker research for a while, have been very convinced, but I was unable to convince my colleagues for 3 or 4 years, until we did another trial in cardiac surgery patients, and the cardiac surgeons were finally convinced, and then they essentially asked for the biomarkers. So, and when they asked for the biomarkers, they got implemented.
John?
Yeah, no, I think it is different in each institution. For us, and remember, these tests, the TMP2 IGP7 was approved for use in the United States by the FDA in 2014. Okay, 2014, and it was already approved a year or two before in Europe. So it's been a decade. Okay, it's amazing when you think about it. Our initial use, I have to say, was wrong. Okay. It was wrong. I would use it in people that I thought had AKI, and it would prove that I was right. And I was like, okay, what do we do that? Occasionally, I'd find a patient, I'd say, I think they're going to have AKI, and they come back with a very low value. And I would say, okay, that's helpful. That's a negative predictive value. I'm going to not worry about this patient's AKI. So you do things differently. But, you really want to find a case that's high risk that you didn't realize. And the only way to do that is to actually use it on a group of patients, right? So all cardiothoracic surgery patients, for example, right? All patients with sepsis, for example. We started implementing approaches where Raghavan Murugan, who I think is still, he's at this meeting, but so he implemented a approach in his hospital where all of the, we call them condition A's, the team goes out to see a patient in trouble on the wards. Often those are patients maximum uncertainty. Nobody knows what's going on with the patient. If they don't obviously have kidney injury, biomarker was used. And then you became very helpful in that case, right? Yep. So eventually we sort of figured it out. And I have to say, the thing that moved the needle most was the pharmacists got involved. And the pharmacists implemented a protocol where they could measure it if the patient was, another nephrotoxic drug was added, and then they would call the physician and say, hey, you've got this patient, he's now on a couple of different nephrotoxic drugs, the biomarker's positive, I recommend that we do X, Y, or Z, I can change it if you agree. And the doc would say, oh, yes, please change it. I meant to get to that. So.
Yeah, I need to make 2 comments. We had an opposite experience. It was quite easy at the beginning to implement the use of biomarkers because we had partial funding from a study, so we utilized this. But we started 14 first with the risk analysis in our population, intensive care and cardiac surgery. In 2015, we added the biomarkers in order to understand if the risk assessment could be improved. In 2016, we used to feedback action like nephrology rapid response team and KDIGO bundles. And we demonstrated that we reduced the cost due to development of stage 2 and 3 and the need of renal replacement therapy in patients. In spite of this, in 2017, we still used, but we had limitations from the administration because they said you're spending too much in the biomarker without counting that we had reduced by 19.8% the number of patients that required CRRT, which is a significant number in our institution.
Could I just add, but you may have also reduced the cost by preventing long-term dialysis dependence in 2 or 3 years' time.
Well, this is the other point, but when you have an administrator that is an idiot, it remains an idiot even if you show him that the results are positive. The other point is the little disagreement in a theoretical aspect that John and I have, and I don't know what is the position of Marlis, and it is that he thinks stress is stress. I think that stress is in any case causing some damage to some nephrons. And as I mentioned several times, I love my nephrons one by one. And when you start damaging the nephrons and you start damaging the population of nephrons, the other nephrons get stressed because they are remnant nephrons, and you see the patients after 5 years coming to your office with a creatinine of 1.5. The diagnosis is nephoangiosclerosis, which is a bullshit, because it is the real consequence of subsequent episodes of AKI or stress or whatever that damage little amount of nephrons, but started to put the patient on the slippery slope of the chronic kidney disease. So this is what I think from the nephrologist point of view. I know that when the patient leave the ICU, you're happy and you don't see them anymore.
No. But the reason we call it stress is that we know both clinically, and this is the ischemic preconditioning work, as well as on the bench. You can take I didn't show this, but you can take cells in cell culture and you can subject them to just nutrient deprivation. You can make them unhappy. Right? You can starve them a bit. They do not die. They do not become injured, but they release these biomarkers as a stress signal. Right? Now, is it true that anyone with enough of this going on that you can detect it in the urine? Maybe they already have some nephrons that have been injured. I can't disagree with you. It's possible.
No,
but I know it's at least possible to not have injury and release these.
And you know that if you move from G1 cell cycle rest to G2 cell cycle rest, you may not die as a cell, but you may change your attitude and you start producing collagen, and then you have fibrosis. Anyway, thank you very much. We could go on forever to discuss. Thank you so much.